Hi, my name is Morgan. This is my patient Taylor, and we're going to be doing a neurologic assessment. So Taylor, recently have you had any headaches?
No.
Any head injury?
No.
Any dizziness?
No.
Any convulsions?
No.
How about tremors of your hands or face?
No.
Have you noticed any weakness?
No.
Any problems with coordination?
No.
Any numbness or tingling?
No.
Trouble swallowing?
No.
Problems speaking?
No.
How about a past history of having a stroke or a spinal cord injury?
No.
Any history of meningitis or a congenital defect?
No.
And how about any alcoholism?
No.
Do you have any environmental or occupational hazards?
No.
Okay, so can you tell me your full name?
Taylor Lukes,
And do you know where you're at right now?
at home,
And then how about the date?
February 18th, 2016.
So patient is alert and oriented times 3. And check his pupils. Pupils are about 3 millimeters round, brisk, and reactive to light and accommodation. His Glasgow Coma scale is 15. His eyes open spontaneous. He obeys verbal commands, and he's alert and oriented times 3. So now we're going to check the 12 cranial nerves. First, we're going to start out by checking his olfactory nerve, which is the first cranial nerve. So I'm just going to cover your nostril. Can you breathe okay?
Yes.
How about now?
Yes.
I'm going to have you close your eyes, and I'm going to bring a smell that's familiar to you. You can tell me what it is. Okay?
It's a candle.
Good. Okay, so now we're going to test cranial nerve 2, which is the optic nerve. Normally we would test this with our ophthalmoscope. This is to examine the ocular fundus and determine the color, size, and shape of the optic disc. So we would use our ophthalmoscope. And everything should be clear and round and normal in appearance. Next, we're going to check cranial nerves 3, 4, and 6, which are the oculomotor, trochlear, and abducens nerves. So we're going to check the cardinal movements of the eyes. So follow my pen. Good. And no nystagmus is noted. So next we're going to move to cranial nerve 5, which is the trigeminal nerve. Go ahead and clench your jaw. Good. And then the jaw is unable to be open. So muscles feel equally strong bilaterally. Now we're going to also check his sensory function. So I'm going to have you close your eyes and you can tell me when you can feel when I'm touching you.
Yes. Yep. Yep.
Good. Okay, now we're going to move to cranial nerve 7, which is the facial nerve. So I'm going to go ahead and have you smile. And how about puff out your cheeks? So no air is escaping when he puffs out his cheek, and his smile is equal, and there's no drooping noted on either side of his face. We're going to move to cranial nerve number 8, which is acoustic, and he is going to tell me when he hears me whispering to him.
Yep. Yep.
So now we're going to move to cranial nerves 9 and 10, which are the glossopharyngeal and the vagus nerve. So I'm going to take a tongue depressor, and I'm going to have him open his mouth and say, ah. Good. So usually I would use the tongue depressor. The uvula and soft palate rise in the midline and the tonsillar polaris. They move medially. And usually I would take the tongue depressor and go ahead and touch the pharyngeal wall with the tongue blade and note his gag reflex. Next, we're going to go to cranial nerve 11, which is the spinal accessory nerve. So I'm going to go ahead and have you put your face towards my resistance. Good. Good. And then go ahead and try and lift your shoulders. Good. Okay, and then the 12th and final nerve, which is the hypoglossal nerve. I'm going to go ahead and have you stick out your tongue. Good, and move it side to side. Good. So, and then I'm also going to have you repeat the words light, tight, and dynamite.
Light, tight, dynamite.
Good. Okay, now we're going to move forward with the reflexes, and I'm going to use my reflex hammer. So we're going to start with the biceps reflex. So I'm going to go ahead and hold his arm like this. Good. And contraction of the bicep muscle and flexion of the forearm is noted. Next, we're going to do the triceps. So I'm going to go ahead and have him hang his arm just like that, like it's dead. And extension of the forearm is noted. Next, we're going to do the brachioradialis. So I'm going to go ahead and hold his thumbs like this. Make sure the hands are nice and relaxed. Good. And flexion and supination of the forearm is noted. Next, we're going to do the quadriceps reflex. So I'm going to tilt the camera a little bit. So I would support his here. Good. And extension of the lower leg is noted. Next, we're going to test the Achilles reflex. We're going to kind of extend and abduct the hip here. And we're going to hit the Achilles tendon. And foot plantar flexes is noted. And next, lastly, we're going to do the plantar reflex, which is where we're going to take somewhat of a sharp object and move it in an upside down J to the bottom of his foot. And we should know plantar flexion of the toes and inversion and flexion of the forefoot. Okay, so next we're going to assess his muscles. His muscles are symmetric bilaterally. Patient is obviously in good physical shape, and he reports to participating in heavy weightlifting. Patient's muscles are strong. He's able to work against resistance. His tone is mild and even. Resistance to movement and no involuntary movements are noted. So now we're going to move to cerebellar function. So we're going to first assess his gait. So I'm going to have him stand up. He's going to walk about 10 to 20 feet. And then we're going to observe for any involuntary movements. So go ahead and stand up. Okay, and then go ahead and walk. Good. So the patient moves with a sense of freedom. His gait is smooth, rhythmic, and effortless. His opposing arm swing is coordinated, and his turns are smooth. So next we're going to do the Romberg test. So I'm going to have you stand up. Back a little. Okay. I'm going to have you close your eyes and try to keep your balance. Usually we would hold this for about 20 seconds. So obviously the patient is able to maintain his posture and balance. Okay, so go ahead and have a seat again. Next we're going to assess his rapid alternative movements. So we're going to start out by having the patient have the backside of his hands touch his thighs. And then we're going to have you flip your hands over and have your palms touch. And I'm going to have you keep doing that. And try and go a little bit faster. And a little bit faster. So patient is able to maintain equal turning and quick rhythmic pace. So next we're going to do the finger-to-finger test. So I'm going to have the patient touch my index finger with his index finger, and then he's going to touch his nose, and then I'm going to switch locations of that, and he should be able to keep up with my change of location easily. So go ahead. Good. So the patient is obviously able to keep up with my change of position without any problems. Next, we're going to have him touch his thumb to each finger, back and forth. Good. So patient is able to do that quickly and accurately and smoothly. So next, we're going to do the heel to shin test. So I'm going to move the camera down. So I'm going to have the patient take his heel and move it up and down his shin. So the patient is able to move his heel in a straight line in the downward position. Next, we're going to do the spinothalamic tract and assess his pain, light touch, and any vibration. Okay, so we're going to start out. Patient is going to be able to perceive pain or a sharp feeling versus a dull feeling. So I've got this here. So I'm going to have him close his eyes, and he's going to be able to tell me whether or not what he's feeling is sharp or dull.
Sharp.
Okay.
Dull.
Good. And how about over here?
Dull. Sharp.
Good. So usually with that test, we would wait 2 minutes in between to avoid summation. So for the light touch, we're going to use this here, and the patient is going to tell us when he feels it.
No. No.
Good. So patient is able to appropriately perceive light touch symmetrically, and usually we would assess that on his arms, forearms, hands, chest, thighs, and legs. So next we're going to test vibration. So we're going to use our tuning fork. How you use a tuning fork is you hold it at the base, you slap it at the base of your hand, and it vibrates. So we're going to take the base after it's vibrating and touch it on the patient's bony prominence of the fingers and great toe, and he's going to be able to tell us when he can feel the vibrations.
No.
Good. So patient is able to successfully note the vibrations or buzzing sensation noted on the distal areas and proximal spots are all normal. So next we're going to do position or kinesthesia. The patient is going to be able to identify which way I'm moving his fingers. So you can tell me if I'm moving your fingers up and down or side to side.
Up and down. Side to side.
Good. Okay, and now we're going to do tactile dissemination. So in order to do this, the patient has to have a normal sense of touch and position sense. We're going to test stereognosis. So I'm going to give him a familiar object with his eyes closed, and he's going to be able to tell me what it is. So go ahead and hold out your right hand. Tell me what that is.
It's a pen.
Good. And how about this? In your left hand?
That's a screwdriver.
Good. Okay. So the patient being able to identify with his left hand indicates right parietal lobe function, and the patient being able to indicate what the object is in his right hand indicates left parietal lobe function. And he is able to correctly identify the objects. So next we're going to do graphesthesia. So I'm going to draw a letter or a number on the patient's hand with his eyes closed, and he's going to be able to identify what it is.
A T.
Good. And how about this?
A 6.
Good. So the patient is able to correctly identify or read the number traced on his skin. And lastly, we're going to assess the 2-point discrimination. So the patient is going to be able to tell us when 2 points being touched on his skin, when he's no longer able to differentiate the 2 points, and when they turn into 1. So we're going to use this paper clip. And give me your finger. Okay.
2, 2, 2, 1.
Okay. So the patient is able to no longer feel the different points at about 2 millimeters, which is normal, and it's a little bit further apart if you assess that on his back or shoulder blades. And that concludes this assessment. Thank you.